Welcome back to pharmacology. Let's take stock of some of the key concepts that your readings should have developed by now. And the first concept was pharmacodynamics, that drugs act at targets. We wanted you to, through your readings and looking at diagrams, build up a picture of where these targets are in the body, and that they're largely proteins. If they're not, they're DNA. So we looked at how you have endogenous ligands, steroid hormones, that bind to a substance in the cytoplasm. The complex that moves into the nucleus, and the ligand receptor complex affects the transcription of the DNA. So drugs, steroid hormone drugs, can also bind to that same receptor site. But we saw that the receptor is usually in a membrane. We developed the concept of it being in the cell membrane, perhaps a G protein coupled receptor or a kinase linked receptor. Sometimes it was a ligand-gated ion channel. So here there is an endogenous substance that binds, thereby opening up the channel. It's the ions, though, that mediate the changes in that cell. And the commonest change, of course, would be depolarization of that membrane. We saw, though, that there were other types of proteins in the body, just ion channels, carrier transport proteins, enzymes. All of these substances, these protein-based substances, targets for drugs. So then we built this concept of, well, that drug might be binding at that protein target and in some way having a similar action as the endogenous substance. So we measure that drug and its efficacy. There may be some other drugs we saw that only had a partial response at that receptor. We called them partial agonists. And then we saw alternatively there were those drugs that blocked at that protein, and they were antagonists. So these antagonists not only working at receptors in the body, but enzymes were also susceptible to drug inhibitors that blocked the normal substrate binding to that enzyme and thereby changed some physiological function through the actions of that drug. So now we're really getting into the pharmacokinetic concepts. We've looked at pharmaceuticals, how that formulation phase of designing your drugs can really enhance or perhaps even slow down the absorption. And absorption was one of our first pharmacokinetic parameters. We looked at absorption by many routes, and now we'll go on and look at this concept of bioavailability. Whatever route that drug is administered, we are looking at, once it reaches the systemic circulation, measuring that fraction that is unchanged drug. And that fraction is your bioavailability, because it's available to have its biological action at the protein target or other target in the body. We will see that with oral administration, bioavailability is much less than 100%. With the intravenous route of administration, it may be close to 100%, but with the oral route, there are many enzymes in the gut. There are the gut contents itself, how hydrated that person might be. Various factors that affect absorption, but one major pharmacokinetic parameter will be this liver biotransformation, how there are metabolizing enzymes in the liver that have the role of enhancing elimination. So it might be first pass metabolism or a first pass elimination effect, a pharmacokinetic parameter. So to help you get your head around this concept of bioavailability, we've used this mathematical example here where we have a drug which was taken in a dose of 100 milligrams. Just to make the maths easy, we've looked at that fraction of the drug that was not absorbed. Lack of absorption of a drug from the gut might be because it is too hydrophilic, not lipophilic enough. Some substances need to be quite water-loving, hydrophilic, but to enhance the drug, sometimes they may need changes in the formulation, changes in their chemistry so that they become more lipophilic and available for absorption. So here we had a drug that was reasonably lipophilic and 80 milligrams of it was absorbed. 20 milligrams, though, is wasted in the feces, so direct elimination, unchanged and unabsorbed. So of that 80 milligrams that was absorbed by the gut, went into the portal vein, 60 milligrams of it was removed by the enzymes in the liver, these biotransformation enzymes. This left us with 20 milligrams of the original available dose that reached the systemic circulation. So the bioavailability of this drug is that 20 milligrams. It's expressed as a percentage of the original 100 milligrams. So it's a bioavailability of only 20%. So that's quite low. And as we said, that's quite usual for substances taken by the oral route, where you get this very high first pass metabolism and elimination effect, either in the gut or in the liver, where that metabolism and enhanced elimination can occur. So here we look at some various routes of administration and typical bioavailability measures. And as we said, with the intravenous route, we tend to have close to 100% bioavailability. So we have the most rapid onset. That can too have its negatives, and you will look at the pros and the cons of various routes of administration, and this bioavailability concept will be one of the major points of contrast and comparison. So the intramuscular route can sometimes be close to 100%, but depending upon the size of the dose, it can't be too large a volume because that could be painful in muscles. So that could limit the bioavailability down to, say, 75%. I suggested that the subcutaneous route might be a very common parenteral route that you find your clients needing to use to take medications, particularly insulin, and we'll look at that in more detail when we look at the drugs affecting the endocrine system. Now, once again, there are limitations to the use of the subcutaneous route. We'll look at it in some detail for your clients with diabetes mellitus type 1. We need small volumes here once again because the route can be quite painful. It does depend upon the person's subcutaneous fat tissue and the capillary network. So bioavailability could be as low as 75%. And with the oral route, in our example that we gave, a bioavailability of 20%, but it can be as low as 5%. And you'll notice there in the table, it is never 100% when drugs are taken by the oral route. But it is the most convenient. And so even in herbal medicines, it's generally the oral route of administration. But you have to be aware that the same principles apply. With your herbal medications, they will be subject to a high first-pass metabolism effect and high first-pass elimination then. This will be quite significant when it's the oral route. Abbreviation PO, per oral. So with the per rectal route of administration, some of that substance is not absorbed through to that portal vein. Therefore, you have some of the absorbed medication that goes straight into the systemic circulation. We therefore get improved bioavailability. But you'll see once again that that can depend upon rectal contents, level of hydration of the client. It's hardly a convenient route of administration, and so on. So inhalation route, very rapid onset, but very unreliable. A lot of drugs can't be taken because they don't volatilize to a gas or a fine mist, so they can't be inhaled. And so you'll see bioavailabilities similar to the per oral route. Transdermal route, we can alter the lipophilic qualities of either the formulation or the drug itself. It's a slow absorption route for substances where an onset of action over a week is quite reasonable, but where you then want a prolonged action over several weeks, that transdermal route might be quite useful, and you get quite good bioavailability so long as you can alter the formulation and that the drug does lend itself to transdermal patches and transdermal administration. So to have a look in some depth then at this other pharmacokinetic parameter of distribution. Our aim is to get this substance to its target protein or its target DNA or its target cytoplasmic receptor, where the complex of drug and receptor will move into the nucleus and affect transcription. So all in all, we have to distribute this drug in general to a circulation, not always the systemic circulation, as we'll see with some of the other routes of administration. But in general, it will be very important then how rich a blood supply and a capillary network is in that tissue, and that will affect how rapidly that drug distributes to the various sites in the body. Once distributed, that's when it can have its pharmacodynamics. Distribution can also refer to how that substance might become sequestered away in one site of the body, transferred to another site in the body, so it's quite reversible. It's not irreversibly bound to one part of the body, and so there can be redistribution. One of the compartments where it's redistributed, generally the blood, and in general terms it's from the blood where it is then distributed to its site of action, its protein target or its cytoplasmic receptor target or the DNA, and there the drug then has its pharmacodynamics. So there are many, many factors affecting distribution. I indicated the level of capillary perfusion of that particular structure, but it might be the function of that person's cardiovascular system at distributing that drug. And so you'll appreciate there's various lifespan issues that might come into play when looking at the cardiovascular system and how it can affect distribution of drugs. We also want to look at various barriers, and we'll look in some depth at the blood-brain barrier and the placental barrier. But also one important concept in terms of distribution of drugs and pharmacokinetics will be how much substances in the body bind to that drug. In the plasma, we'll be very interested in certain proteins that form these drug-protein complexes. While bound, that's not a free drug, and so it can't bind to its own receptor target or enzyme target. It's only the free drug that can bind, but often that drug-protein complex is a reversible complex, and so the bound drug can be redistributed in a dynamic process to the systemic circulation and thereby to its target molecule. So that dissociation, it's an equilibrium. It's only the free drug that has its action and is therefore bioavailable. So we're saying distribution to these protein binding sites can affect bioavailability, but it is this equilibrium. It is reversible. However, we'll see for some other interactions that might affect the level of that protein binding, that can affect the levels of some drugs in the plasma, particularly ones that, as far as their toxicodynamic profile goes, are drugs with a very low safety margin. But more on safety margins when we look at toxicodynamics and toxicokinetics in general, after we introduce the principles here by looking at pharmacodynamics and, of course, here the pharmacokinetics of drug distribution. So as to which proteins a drug binds depends upon its chemical nature. Acidic drugs will mainly bind to albumin. I want you to recall when you looked at metabolism that you saw that fatty acids bind to albumin. So we're saying it doesn't necessarily have to be a hydrophilic drug. It can have these rich lipophilic sections to it, but so long as there is an acidic functional group, that drug may bind to albumin. So here we have a drug A, shown in yellow, binding to some sort of plasma protein, say albumin, shown in pink. Basic drugs likewise will have a plasma protein, but it's often a glycoprotein that they bind to. So these basic drugs might have amino functional groups on them. Other drugs that might also be acidic in nature might compete with that first drug for their binding site, in this case being an acidic drug. That would be our albumin plasma protein. And so here we have a second drug, drug B, and one drug displacing the other drug at its binding site. And as we suggested, generally not a problem with drugs, doesn't cause significant interactions unless one of those drugs has this low safety margin. So more on that later. Therefore, if the amount of a drug that's available at the site, the molecular target, the protein in the tissues or on the membranes, depends upon this pharmacokinetic parameter distribution, then one of the factors that can affect distribution will be how many blood proteins you've got. If you are on a diet low in protein, if you're in a famine situation in the geographic part of the world where you live, well, then you would produce less glycoproteins and way less albumin. Therefore, levels of drugs will be far greater. Those with a low safety margin, that will be a problem. So when we look at these drugs with a low safety margin, we're going to be looking at ones such as digoxin, which has actions in the heart, or lithium. We'll see that it's used in treating manic depressive disorders, and here the lithium as a drug has this low safety margin. So we'll be interested in looking at factors that affect distribution of these sorts of drugs. But with other drugs in general, if a person has a liver disease, that might be the reason why that drug is used with caution, or perhaps even contraindicated, because less of that drug may then bind to plasma proteins. Most of those plasma proteins, the glycoproteins, and certainly the albumin, being made in the liver. So if a person has a burn, they'll compartmentalise much of their plasma to this serous ooze in the burn, and those plasma proteins are there at the site of the burn having their very necessary actions, but they'll be unavailable in the blood then, making that person perhaps more susceptible to various drugs. So factors that might increase the number of blood proteins could also bind too much of a drug. People that have a cancer where they produce too many immunoglobulins, for example, a disorder known as multiple myeloma, may have so many of these immunoglobulins that they bind drugs and change the responses that that patient might normally show to those drugs. So once again, stressing that this protein binding affects distribution parameters, and so this pharmacokinetic parameter can have implications for the pharmacodynamics, how long it takes for that substance to have an onset of action in its target tissue. But once again, as shown by the arrow, many of these plasma protein binding sites don't irreversibly bind drugs, and that there can be this equilibrium between bound drug and unbound drug so as to release more unbound drug available to the systemic circulation and then available to the site of action. We did indicate, though, that distribution can depend upon the chemical nature of the drug, and one concept we want you to recall from biochemistry is that those substances that are quite lipophilic, love lipids, will be hydrophobic. They would, because of their lipid-soluble nature, distribute to adipose tissue. So we'll say they will have a high affinity. There will be binding sites, not necessarily the target, you understand, but some other tissue binding substance to which they have a high affinity. And so then the pharmacodynamics and the time of onset of that action in the tissues will depend upon how slowly that substance is then redistributed from the fat and back into the systemic circulation. So generally, lipophilic substances will be slowly released from the fat. Other sites where drugs might have a distribution and a binding substance, we've used tetracyclines that have this high affinity for bone. In fact, many of the tetracyclines stain bone brown because of this high binding and high distribution to bone. Tetracyclines are often contraindicated in pregnant women because the fetus is developing the growing teeth buds and developing new bone structures. And so you don't want these drugs distributing and perhaps concentrating in the tissues of that fetus. Tetracyclines are also, many of them, contraindicated in the young while they are still developing their own tooth buds and growing their second teeth. And there's one example of people from the early part of this century where a lot of discovery of new antibiotics was occurring, and these tetracyclines were newly discovered and tried, and many children, through pharmacosurveillance, found to develop these brown stains on their teeth. And the Queen Mother, that is our current monarch here in the Commonwealth of Australia, her mother had these brown tetracycline stains on her teeth, so she would never smile before the cameras to show those brown stains. That will help you remember that example of distribution and high affinity tissues. Most people think of lipids, but remember those tetracyclines and bone for when we look at toxicodynamics of substances, and then subsequently later go on and have a look at antibiotics as drugs and look at their pharmacodynamics and pharmacokinetics. Well, that leads in nicely to then looking at distribution from the point of view of where are the barriers to distribution in the body. And the blood-brain barrier is one of those major points where some drugs might be designed so that they cross easily. They are meant to have their action in the CNS, so they've been made more lipophilic to cross that really lipid-rich blood-brain barrier. This is more of a physiological barrier than an actual anatomical structure. We see that here in the capillaries and the arterioles at the brain, the endothelial cells just have much tighter junctions. There is a more fatty sheath around the glial cells that protect other structures in the CNS, and they form tight junctions with the endothelial cells. So it's quite a physiological barrier, a barrier of membranes, making them more lipid-rich so that generally lipid-soluble substances will cross. And alcohol, though it has that water-loving functional group, has the hydrocarbon section, which then makes it able to cross that blood-brain barrier. So you'll look at alcohol as an example of a toxin, where you look at this toxicokinetic parameter of distribution, and then we'll later go on and have a look at other substances that are drugs that act in the CNS and have this pharmacodynamic action in the CNS, but first have to overcome this pharmacokinetic parameter of crossing that blood-brain barrier. So we want to distribute these drugs to the cerebrospinal fluid, and thereby they will be delivered to the parenchymal structures in the brain or other parts of the brain. This blood-brain barrier, this physiological barrier that has evolved over time, is a defense mechanism. I used as my example alcohol, an actual toxin, and I said we'll study it more when we look at toxicokinetic parameters. So it's important then to realise, being a defence mechanism, a physiological barrier, it becomes leaky under certain conditions. It's designed for those tight junctions to be less tight when the person has a fever. Under these situations, then more drugs will penetrate into the brain than perhaps had been accounted for by that dose that they were originally given. So the placental barrier, another important barrier that will be put up to the passage of drugs, and as we'll see, it's largely a fairly non-selective barrier and allows the passage of most drugs. So it's way less selective than the blood-brain barrier. Lipophilic substances will, of course, cross into the fetal circulation by that placental barrier, but so will many hydrophilic substances, water-loving substances, be able to permeate the circulation of the maternal circulation across that barrier and then into the fetal circulation. So remember that those two circulations never actually directly mix. Substances just diffuse out of the maternal circulation across this rather non-selective barrier and into the fetal circulation, and so drugs will as well. We'll continue on looking at other factors that affect the actions of drugs at their target site. We'll look at some other pharmacokinetic parameters apart from absorption effects and distribution effects. We're going to have a look a little more detail at first pass elimination effects, so that will involve looking at biotransformation. Biotransformation, a term that's used in general for toxins, and when it comes to drugs we just call it drug metabolism. But before we have a look at those, we would like you to consider this particular case study. And we have picked a person who in their lifespan is 92 years old, and get you to have a look at this lady's situation, Janice, and to consider, as her natural health practitioner, how many of her Western pharmaceutical drugs might be impacting on her particular case. But mostly what we want you to consider is, being elderly, what are some of the pharmacokinetic parameters that are important here? So consider absorption and distribution effects in the elderly.